I mean, if I start changing my therapies in the way you're describing, I'm going to go against guidelines in many instances. I have a really great treat for you all. I have with me Professor Monreal, who came all the way from Spain to Washington, D.C., actually to sit with me somehow and talk to you all. And Professor Monreal is an expert in one very important thing that is relevant to all of us. He knows how to treat patients with venous thromboembolism, DVT and PE. But the cool thing about his knowledge is that he doesn't do a one-size-fits-all like most of us do. He goes well beyond the guidelines, dives into the details, and he's going to help us dive into the details so we could do the same and help our patients better. So, Professor Monreal, thank you so much for coming to the Vascular Scientific Sessions. I appreciate it.
Thank you very much, and thank you for inviting me to be here. May I correct you?
Yes, please.
I am an expert in nothing. I am not an expert. No, I had the opportunity to manage a database with data from over 100,000 patients with VTE coming from real life. And I learned a lot of this, but I am not an expert.
I want to just stress for the audience what you just said. Professor Manuel basically sits on top of a mountain of data of more than 100,000 patients with VTE from all over the world. Now, are these real live patients or are these study patients? Are these patients that I see every day in my clinic?
These are patients from real life. We set up the database, the registry, 22 years ago in 55 Spanish hospitals, and since then we try to expand the registry to other countries. And nowadays we are in 28 countries and have data on over 118,000 patients followed up for at least 3 months, and all of them are by contract consecutive. We just to make sure that they are representative from patients from other countries, we recently compared and published a study comparing the data, the clinical characteristics, treatment, and outcomes from the RIETE patients with those in Medicare, patients with PE older than 65 years. Patients with Medicare are much more common, but patients in RIETE have a more granular information. Most of the clinical characteristics of the patients in the two databases are very similar.
So I just want to give our audience 2 sound bites from this, just so you can take that with you. The first is that the registry is called the RIETE registry, and you're going to have a link in the comments section, and we're going to have publications in the description. Part of my problem when we're going to edit this video is that there are hundreds of publications that came out of RIETE, and so I just can't give you it all, but we're going to give you a link to the site at least. And the second soundbite that came out of this is that these data are representative of patients that we all see every day. Now, here's why this matters. So when I treat patients, I try to go by, my knowledge of the data, and I try to go by guidelines. I try not to kind of exceed my boundaries, right? But what is it that you learned that means that we can help patients more by going beyond the guidelines and diving deeper into the details? Give me examples of real life sort of situations where I can do better for my patients by knowing the data better.
For instance, if we focus on cancer patients with VTE, we learned first that cancer patients presenting with DVT should not be treated the same as cancer patients presenting with PE. We learned that the outcome of VTE in cancer patients largely varies according to the cancer site, and even among several cancer sites according to the histology. We also learned that there has been a progressive improvement in the outcome of cancer patients with VTE. We compared the trends during the last 20 years, and the most important issue is not only that there was a progressive decrease in mortality, but there was a progressive decrease in the VTE recurrences rate and in the measured bleeding, but much more pronounced in patients with in the decrease in VTE recurrences. So 22 years ago, the rate of VTE recurrences was very close to the rate of measured bleeding. Nowadays, the rate of measured bleeding slightly decreased, the rate of VTE recurrences decreased profoundly, and nowadays there is 1 VTE recurrence for every 2-3 measured bleeds. So we need safer treatment.
Amazing. So again, I just want to give you all just the sound bites from this, the take-home messages. Not all cancer patients are the same. It's difficult, but we still need to understand what kind of cancer a patient has, what the extent of the cancer is. And the second super important thing is remember that cancer treatment has been advancing, has been making huge advancements, and that has affected outcomes related to VT and to bleeding. We really need to understand bleeding risk when treating our patients with cancer, and we have to remember that recurrence risk may be actually much lower than bleeding risk in some of these patients. Give me another example. What about a common patient? All of us see a patient with renal insufficiency. What happens with those? Am I supposed to treat them differently?
Yeah, every time I have been called in the ICU or in the nephrology service to attend a patient with severe renal insufficiency and VTE, my mates were very concerned about the risk of bleeding. What we learned from RIETE is that yes, this is certain. The rate of major bleeding increases with the decrease in renal function, but the most important challenge is fatal PE, because patients presenting with PE and severe renal insufficiency, the most important challenge, the most common cause of death is PE itself, much more than bleeding. After the first 10, 15 days, we may think in reducing the dose, but not at the very beginning.
So we may need to change our paradigm of how we treat patients with renal insufficiency. Maybe we need to risk bleeding during the first very high-risk couple of weeks and only then change our treatment further down the road. Now, why, just practically speaking, I mean, if I start changing my therapies in the way you're describing, I'm going to go against guidelines in many instances. And I bet many of the people watching, myself included, to be honest, I'm afraid to do that, right?
Yeah.
So how do we get data like yours to be mainstream, to be adopted by whoever needs to adopt them?
Yeah, the first thing I would like to comment is we are not against the guidelines. I think our registry and other registries are complementary. We can, the data in RIETE are hypothesis generating. They don't help to conclude what is the best therapy for a particular subgroup of patients. But we learn that tailoring therapy according to a number of characteristics of the patients helps to improve their outcomes. And if you want to share this data with us, you only have to enter in our website, www.rieteregistry.com. It's free access for everybody without needing anything that is permanently connected to the database. And there we have several infographics that display a number of characteristics of the patients with filters to select just patients with gastric cancer, just patients with gastric cancer and renal insufficiency, whatever, and you will receive immediately in a graphic way the rate of VT recurrences and outcomes during the first 3 months for all subgroups of patients who is.
And this could be a wonderful tool for shared decision-making as well, right? Do you think physicians can use these graphic tools to have more in-depth discussions with patients to help them make kind of intelligent decisions about their health?
Yes, this is absolutely what I think and what I use in my daily practice.
That's wonderful. So this is Professor Monreal coming all the way from Spain to us, from Catalonia to us. He runs the RIETE registry. It was wonderful, really wonderful, and a treat to speak to you about more in-depth and tailored treatment of patients with DVT and PE, and there's so much more to learn. Thank you for coming. Thank you.
Thank you very much.